The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Reed to review the management of all things venous disease. Dr. Reed is a vascular surgeon at Washington University in St. Louis.
Thank you so much for having me, Julia.
My name is Julia Suggs, and I'm a PGY4 vascular surgery resident, and will be your host for this episode. Today's topic is focused on venous disease. Our main focus during this episode is how to work up, diagnose, and treat venous-related diseases. The focus of the following cases is an acute emergency department setting, and the focus of today is to differentiate when venous disease is best treated by medical management versus surgical management. So, let's dive right into two case scenarios to guide our discussion.
So for case one, we are seeing a 51-year-old male, normal BMI, and no other major medical comorbidities. He had a recent motor vehicle accident approximately 2 weeks ago, which led to a right lower extremity femur fracture. He is now post-op day 13 from an intramedullary nail and came back to the emergency room with a right leg swelling. He stated that he had 3 days of progressive right lower extremity swelling. He has still been able to walk, but with increasing pain. On physical exam, his right leg is swollen to the calf. It's mildly tender to palpation. The extremity is otherwise warm to touch, and the patient has full motor and sensation. He has palpable bilateral dorsalis pedis and posterior tibial pulses. So how would you manage this case?
First line diagnosis, and the thing that we're most concerned about, is going to be a DVT, so a deep venous thrombosis. The first imaging study that we would likely recommend in this case is a venous duplex to first rule out whether there is a DVT.
And the duplex in this patient showed a mid-femoral vein and popliteal vein DVTs. There was no clot in the common femoral or profundifemoral veins. How would you manage this case beyond that?
At this point, I would say there is no further imaging indicated because we don't have any DVTs in the common femoral or the profunda vein, so I would not be concerned that there is a more proximal clot extension. For this patient, I would recommend further here that there is no role for surgical intervention. There is no evidence that there is a threatened limb, but they can probably go home with medical management. For this patient, if they had a normal renal function, I would just prescribe a NOAC, so a novel oral agent, sort of anticoagulation, recommend elevation, and they can discharge home with follow-up.
I agree. The patient can follow up with their primary as long as they don't have any other concerns. So let's talk about a slightly different case. In this case, we're seeing a 33-year-old female who comes to the emergency department with 24 hours of profound left lower extremity swelling. She works as a teacher, so she stands most of the day. She has a normal BMI and is relatively active. She has a long history of heavy menses and takes high-dose oral contraceptives at home and notes that she's chronically anemic. She develops significant swelling of her left lower extremity all the way up to the level of her hip. Her pulses are non-palpable, but she does have multiphasic arterial signals on exam. She has full motor function, but she has developed a dense sensory loss in the left foot. Where would you go from here, Julia?
At this point, I would recommend, again, a left lower extremity venous duplex, but based on the evaluation, whether we could do a bedside venous duplex just to look for the extent of clot into the common femoral vein, I would likely end up getting a CT scan with venous phasing to evaluate for a possible iliocable DVT.
And I would say that CT scan should be of the abdomen pelvis with a venous phase. If she had any evidence of shortness of breath, you could consider a PE protocol scan as well. So the test results show that she has venous clot in the entirety of the left lower extremity from the inguinal ligament down, including the common femoral vein, profundifemoris vein, and popliteal vein. The CT scan showed clot extending all the way up to the left common iliac vein. So what would you like to do next?
My concern for this patient is that she has developing what we would call phlegmasia, so threatened upper limb, mostly based on the aspect that she has loss of sensation to that limb. First things I would recommend is a heparinization as quickly as possible in order to get the patient therapeutic on anticoagulation. That can either be with a dose of therapeutic Lovenox, or we can consider a heparin drip with a bolus. I would say this patient would need to be evaluated to go to the operating room as long as she is stable in other clinical terms. We discussed that if she had any sense of shortness of breath, we would evaluate for PE to make sure she was safe to proceed to the OR without further evaluation.
What operation would you consent the patient for, and how would you set up that case?
So some of this would be a change in answer over the last several years. Historically, this patient would likely be recommended for an open venous thrombectomy because that would still be the most common historic board's answer. I would recommend in the modern era that most likely this patient would undergo a percutaneous venous thrombectomy, but would honestly consent the patient for both procedures.
And typically open venous thrombectomy is more of a historical operation and is not something that we do particularly commonly. And I agree that a percutaneous option would be the best available in this time.
I think both cases we can describe. So the most common thing in terms of a case for a open thrombectomy would be a left groin cut down and then manual decompression of the left lower extremity, which means that you normally typically use an S-mark and actually wrap the leg as you go up and push clot out of the leg distally, and then you use a Fogarty balloon proximally to get clot out. But again, we typically do these cases with percutaneous thrombectomy devices at most medical centers in the modern era.
If you do use the S-mark, you want to make sure that you're elevating the leg as you're taking the S-mark up so you can use gravity to help you get as much of the clot out as possible.
In terms of a percutaneous thrombectomy, you have multiple options, and then there's multiple styles in terms of what people will use for their venous access. Things that you can consider is that you may need to have IJ access, so the jugular vein, popliteal vein, and femoral access, which are probably the most common used accesses in this patient's. Meaning that also you need to talk to your anesthesia team about what lines they are going to have available to them in terms of where they can get their access for the case itself. So if you are planning to do this from a popliteal vein and femoral vein access, which is commonly what we will do at WashU, you will plan to do a popliteal access while the patient is still actually proned on the stretcher. So the patient is awake, they are put prone on the stretcher. You will prep out behind the knee on the left side, which when the patient is prone, you need to make sure that you are indicated that you are on the correct side. And then you will put basically a venous sheath and get percutaneous access using ultrasound-guided access into the popliteal vein. You will then flip the patient onto the OR bed and then proceed with general anesthesia before proceeding with the rest of the case.
One thing you want to remember, in this case, the popliteal vein will be thrombosed. It should be large. It will not be compressible on ultrasound, but you will be able to identify it, especially in acute blood clots. Typically, you put the needle in the vein. You will likely not get much or at all of any kind of blood return, but you can visualize the tip of the needle in the vein. And typically, as long as there's not a chronic or subacute component to the clot, you can pass the wire and then place a small sheath and can perform a small venogram to confirm that you have access.
The next part of the procedure I would proceed is that you're going to plan on having both groins prepped out, as well as I typically will prep out the belly and then the entirety of the left lower extremity for ease of proceeding with the case. I would then proceed with doing a right common femoral vein access in order to get my sheath in place. Things that we do need to think about are the fact that during this case, you put the patient at risk for developing a pulmonary embolism if they do not already have one, and that you need to protect the patient from at least large amounts of clot proceeding up to their lungs, which can be done in two fashions, either with the placement of a temporary filter, or some of the devices have their own sheath, which have a filter built into them. We'll then proceed likely with either a percutaneous mechanical or suction thrombectomy. There are multiple devices that are available at many hospitals, including our own. That is basically in order to decrease the clot burden before proceeding.
One other point I would like to make is, especially in a more subacute or non-emergent scenario, I recommend getting an echo with a bubble study for these patients. For patients who have a patent foramen ovale, they are at risk for clot traveling from the right heart to the left heart, even if it's tiny. And so if there is time evolved and there's not an acute phlegmasia episode, that's what I like to do before proceeding with these.
Agreed. After you perform either your suction or mechanical thrombectomy, we'll often use kind of several ways in order to evaluate whether there is still either residual clot or whether there's an indication for balloon or stent placement. In this case, if this patient were to have what my concern would be for a May-Thurner, which is May-Thurner is the compression of the left common iliac vein by the right common iliac artery, often we will use what's called intravascular ultrasound to evaluate that compression. That allows you to evaluate through the vein whether there is a level of compression, the degree of compression, and how much residual clot is in that place. In this case, you then can consider using a balloon angioplasty and often a stent in order to help alleviate that compression and prevent recurrent DVT.
Following the procedure, you want to make sure that the patient remains anticoagulated. Typically, we do not reverse these patients in the operating room. You can use just a nylon suture and then hold pressure. Make a U-stitch around your sheath, remove the sheath and hold pressure, even though these are relatively large sheaths. And then you want to make sure that you wrap the leg from just proximal to the toes all the way up to the upper thigh with ACE wrap compression, and then elevate the leg in the postoperative period to help manage the swelling.
So I think the things we wanted to address here were, one, the next steps are going to be kind of what the main complications are of this case and how we either prevent them or address them. The main thing I think we had talked about is that you can cause a PE, and often we said that you can use either a filter or a device. I will also say that if you have the complication of a PE, you can then consider trying to either do a suction thrombectomy of the PE itself if you're concerned that it's large enough and hemodynamically compromising for the patient.
The other thing you want to make sure is that all of these patients have a type and screen. Even though some of the devices are set up to return some of the blood after suction or mechanical thrombectomy, there's still a reasonable amount of blood loss. And if someone, especially in this patient who's chronically anemic, it's good to consent them for a potential transfusion, even though it's a percutaneous operation.
I think the next thing we wanted to focus on is kind of what the difference between these two patients were and why one required a medical management versus why one was proceeded to the operating room in a more urgent or emergent fashion. So in the first case, the main difference between the two presentations we had were, one, the first patient had one, known palpable pulses, but the more importantly was that they were motor and sensory intact. And then two, they only had DVT up to the level of kind of the mid-femoral vein, so did not have any iliocaval involvement, which often does not require, and honestly recommended that they do not have a surgical intervention in those patients. Our second patient had the known sensory loss, so the concern was that they had an acutely threatened limb and also had the iliocaval clot component.
The other thing that you do want to think about when you have patients with significant venous clot burden in a proximal fashion is that you can develop venous compartment syndrome. And so certainly that's something you want to have a high level of suspicion for, and certainly make sure that you're addressing that even after treating them for the clot as well.
Thank you so much for being with us today. We got through a ton of great information about venous disease. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of venous disease can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.